Tonight, we are really honored to have some tremendous speakers who will represent, I think, important perspectives on the Affordable Care Act. As you all know, the Affordable Care Act was one of the most important enactments during the first term of President Obama. Certainly, it's been the most controversial. While many have celebrated it, others have criticized it. It is still an act that is being implemented. We've seen tremendous success of that enactment in California, not in a small part to our guest tonight, who is the executive director of Covered California. But still, there are many people who think it could be improved. Someone is outright overturned. But we think it's important that our community be informed. We've seen a lot of propaganda on the Affordable Care Act, so-called Obamacare, and even Covered California. Today we want to talk about the facts. We want to see where we are, and again, importantly, where we're going.
I think it's a very special series and partnership that we have, because as an educational institution of higher learning, we want to make our learning experiences relevant and inform our community that we are well aware of the issues in the community. So one of the opportunities we have in this collaboration is to further develop the lecture series and bring these issues to the forefront, not only for our students, but our community members.
The Freedom Center is proud to co-produce the Barbar and Elihu Harris lecture series. Today, we present the 9th lecture in the series. We hope the lectures provide our community with important information that you feel ties the past with the present and prepares us for the future. The Freedom Center produces classes and civic engagement opportunities to middle school and high schools all over the East Bay. Our classes are based on reading, writing, and analytical thinking skills. Freedom Center students organize in the community in the struggle to have every school provide excellent education to all. We organize interracial, intercultural exchanges, developing our mutual understanding of local, national, and international dreams and needs. Let me say something specific about what we do. The average time a student watches TV and surfs the net when they enter our program is over 6 hours a day. We help reduce that time to less than 6 hours per week. We encourage ourselves to close our Facebook accounts and get rid of the game stations because Dr. King teaches that it is important to live in society without the negative aspects of society living in us. Thank you.
Like many of you, I get a little discouraged about our young people. When you hear young people like these, there's no reason for discouragement. Everyone should have.
I'd like to bring up Dr. Coynus Enix, who is going to speak to you from his perspective about the Affordable Care Act and its importance to you. Please welcome Dr. Enix.
Before this year, some 45 million people were uninsured in this country. As of about a week ago, some 15 million of that group have been insured now because of Obamacare. Now, I'm glad that pleases you, because that also means that 30 million people are yet to be insured, so we still have a lot of work to do. Now, I've practiced here in this community over 25 years, but I was born in Nashville, Tennessee, on a street called Jefferson Street. And anyone who's been to Nashville will recognize that iconic Ritz Theater. I was born on 10th and Jefferson Street in a clinic at that time was known as Dr. Alleen's Clinic. You see, Dr. Alleen and his family lived on the second floor, and on the first floor is where he maintained a health clinic, and that's where I was born. Now, the records show that I weighed 8 pounds and 3 ounces. Now, you will see here that the delivery fee was $3 and the clinic fee was $4 for a total of $7. So my weight was more than my worth. My wife reminds me of that when she's after me to lose weight. My dad knew the doctor, Dr. Alleen. He selected Dr. Alleen to deliver me. He knew exactly how much Dr. Alleen's fees were. Now, I grew up with 2 brothers, one Frank and one Russell. My interest in medicine was first piqued during those years when I realized that, by golly, if I got whooping cough, Frank would get whooping cough. If Russell got the measles, I got the measles. If I had a sniffle, Frank and Russell would sniffle. And I'm thinking, how did that happen? So what I did notice, however, was that Dr. Crump, Dr. E. Perry Crump would come and he would treat us. He would see all of us when we were ill. And my dad would pay him $5 sometimes. Sometimes he would pay him $10. Now, my dad knew Dr. Crump just as he knew Dr. Alleen. He selected them both. He knew how much they would charge. He knew that the charge would be low. He had the ability to shop around. In other words, the relationship between my dad and those doctors during the 40s and 50s was classical free market capitalism. But over the decades, that would turn around. It would reverse course, topsy-turvy, such that there was less competition. There was less choice. There was an inability or less ability to shop around. And of course, there was the influence of the insurance industry. And over the decades, all of that saw a massive escalation of the cost in healthcare delivery to the tune of $2.7 trillion, and it's more than that now. Now, when I was a young surgeon, this is an old picture of me. It looks like I'm replacing a valve there. But all I could think about was operating and seeing the next patient. Didn't think much about healthcare delivery. But I did recognize that the cost of healthcare delivery as it pertained to cardiac surgery was rather expensive. And I understood that the materials, the prostheses, the equipment, I understood that it was quite expensive. And again, patients told me so, and I recognized that. But it wasn't until I began to travel abroad that I realized that the cost of heart surgery in other countries was a fifth, a fourth, and maybe even a smaller element than cardiac surgery in the United States. And I just didn't understand that. How could that be? I later learned that physicians' fees were extraordinary in the United States, not so in other countries. Same with hospital fees. As it turned out, the average US price for a hospital admission was 5 times that of France. And so I had an epiphany. It occurred to me that in order to get high-level medical care in this country, you either had to be famous and wealthy, or famous and wealthy and funny, But either way, you had to have good insurance. It was during that same period of time, during the 80s, that the American Heart Association published several papers indicating and clarifying that there is a direct link between poverty and chronic health conditions, including even depression, asthma, obesity, diabetes, heart disease, and all the rest. In the greatest country on earth, in a country that spends 2.5 times the average of all other industrialized countries together, this was going on, and in order to get health care, you had to be wealthy or moderately so. So that's when I decided that in America, health care should be a right and not a privilege. Now, this is an old stock photograph from Nashville, Tennessee, Meharry Medical College. And I can remember quite vividly when I was growing up, I didn't live very far from Meharry. I can remember that I never knew anyone who was hospitalized. Hospitals had a different value, a different reason for being than they did in later decades. As a matter of fact, they were mainly meant for vagrants or very, very ill people who were dying, the insane, and so it wasn't a place that I wanted to be. But that would change over the ensuing years, whereas in every major city, there would be several hospitals. The hospitals would get larger and larger. Cleveland Clinic, Atlanta, New York, Bellevue, there in New York. And it was during this very same time that insurance, health insurance, hospital insurance, was having a great influence. Now that happened up until about the mid to late 80s, when a phenomenon took place called provider consolidation. You see, it was during that period of time when hospitals began to buy up each other, mergers of hospitals. Medical schools would begin to control hospitals, and that has continued to this day. Now, you would think that with this increase in efficiency, that it would benefit you and me, the customer. You would think that either it would improve hospital care, or at a minimum, the cost would go down. Ladies and gentlemen, provider consolidation did neither of those things. Provider consolidation gives hospitals greater negotiating strength and limits competition, resulting in higher prices for services, higher cost for patients, and no improvement in the quality of care delivered. During the years 2007 and 2012, 551 hospitals were acquired by other health systems. You see here on this graph, over time, hospitals merger and accelerating spending growth. So you see in the late 80s and early 90s, when there was an exponential increase in hospital mergers, this was quickly followed by an accelerating spending spurt that started in the mid-90s. And billions of dollars would flow from insurance companies into hospitals, and insurance companies would charge you and me higher premiums. That's the way it worked. The indomitable trifecta, hospitals, spending, and health insurance, inextricably bind together, supporting each other, moving ever toward an increasing cost here in the United States. Now, of course, you might say that technology perhaps had a lot to do with that, and that's true. Technology did have something to do with it. When technology is compared with other factors, such as administrative cost and demographics, technology certainly stands out. But when you think about it, all other industrialized countries, Switzerland, Canada, Sweden, United Kingdom, also had access to technology. So technology alone did not indicate why here in the United States the cost exponentially increased. So why are the costs here in the United States so high? Now, you've heard all the reasons. Everything costs more. Overutilization, obesity and cigarettes, inefficiency, defensive medicine, you've heard them all, malpractice, need for tort reform, and so forth. Well, a lot of those just didn't make a lot of sense. So what is the true reason? The true reason is right under our nose, and it always has been. The U.S. consumer have no centralized negotiations, therefore little leverage on price control with hospitals, healthcare providers, pharmaceutical companies, and medical device companies. So in effect, hospitals, providers, drug companies, and device companies, in effect, charged whatever they thought they could get away with, and they did. Now, you don't have to take my word for it. I'm not a bad fellow, believe me. You don't have to take all you have to do is to go online, and you will see the differences. You will see, for example, a colonoscopy in Switzerland costs $655, while in the U.S., $1,185. A hip replacement in the U.S., $40,000. In Spain, $7,000, and so forth. And those are real numbers. And the same is true right here in our beloved California. If you take a mean cost of common surgical procedures, what you will find right here in our state, that there is a variation of between 60 and 140%. Right here in the San Francisco Bay Area, the same surgery can vary by some $10,000 between hospitals in the same town. I won't mention the hospitals, but I know for a fact that that's true. If you go over to Cincinnati, you can be admitted for a myocardial infarction, a heart attack, and within an 8-mile radius, there can be a difference of some $25,000. So think about the stakeholders in healthcare reform: the pharmaceutical companies, the insurance companies, the politicians, the business leaders, hospital associations. If you think about them, then you recognize and you're not surprised by the lobbying expenditure that takes place in this country by the health industry. Near the top. As a matter of fact, between 2009 and 2011, medical supply companies, pharmaceuticals, and biotech firms spent in excess of actually closer to $800 million. So it's not surprising that over the decades, hospitals and physicians and pharmaceutical companies together account for in excess of 80% of the healthcare dollar. Think about the pharmaceutical company and compare pharmaceutical spending in this country compared with all other industrialized countries, and we spend twice as much than the average of all other industrialized countries combined. Think about that. These factors are reflected in the profit margin by those industries. Look at that. Major drug manufacturers, profit margin near 18%. Medical instrument and supply companies, profit margin closer to 14%. Now, another way of thinking about this is think of it as sellers or buyer's market. Is it a seller's market? Is it a buyer's market? Well, the national health expenditures over the last 50 years have gone up some 818%, while the gross domestic product, 160%, and the wages, a paltry 16%. So it certainly is not a buyer's market when we are close to the bottom when it comes to infant mortality rates. It's not a buyer's market when out of 20 industrialized countries, we are 20th in terms of life expectancy. And this one will surprise you. Doctors in the United States see patients, per 1,000 patients, far less than the mean, the average, of all other industrialized countries. Now, reshaping healthcare delivery did not start in the last 20 or 30 years. Actually, it started in 1909 with Teddy Roosevelt, FDR, Kennedy, Johnson, Clinton. It was on March the 23rd, 2010, when Barack Obama signed the ACA, the Patient Protection and Affordable Care Act. Now, it's important to understand the words in this law: patient protection and affordable. So it is patient central. The law has two overreaching goals: improve the health care for all Americans, not just uninsured Americans, but for all Americans, and slow the growth of medical costs. Now, the uninsured group is important. They make up 16.3%, or some 45 million people. There are 5 problems addressed by Obamacare. The U.S. spends 18% of its gross national product on health care. Family premiums cost $14,000 on average a year. Patients can be turned down by pre-existing conditions. Cost can lead to financial ruin. And, of course, the uninsured. Now, there are 6 solutions. The solutions are complex but very specific and are far more reaching than simply insurance coverage. Number 1, make coverage more secure for those who have insurance and extend affordable coverage to the uninsured. Solution number 2, improve health care quality and patient safety. Very important. 3, emphasize primary and preventive care linked with community prevention service. And number 3 is going to bring the cost of health care down over time. Number 4, reduce the growth of health care costs while promoting high-value, effective care. Very important. Ensure access to quality, culturally competent care for vulnerable populations. And 6, promote the adoption and meaningful use of health information technology. Now, healthcare.gov is a tool. It's a tool of the government, just as surgeons have tools. It is a tool. And essentially, it makes transparent to the customer, to you and me, the various nuanced differences between health plans. In other words, it is a marketplace that you can shop around. Now, while any and everyone is eligible as long as you are a citizen, it's not for everyone because some people can't afford it. There are exchanges in all 50 states, including California. Someone mentioned it was the first. The state-based exchanges, there are 17 in number. The federal-based exchanges, there are some 27 in number. And for 7 states, there is a hybrid. Now, it is important to understand that the marketplace subsidies was not even meant for the entire population of the unemployed. It was meant to be sort of an adjunct to other means, Medicaid. Now, you see Medicaid on one side of the umbrella and the marketplace subsidies on the other side. That leaves a significant gap. Now, the gap was intended to be closed by the expansion of Medicaid. That's why the expansion of Medicaid is so important. But unfortunately, some states refused Medicaid expansion. And it's fascinating. I think, it's interesting to see, but the various states that could benefit the most from Medicaid expansion are the various states with governors who refused Medicaid expansion. I'm sure if someone were to come down here from out of space and took note of that, they would, what's up with that? I mean, it makes no sense. But that's the way it is. But I am convinced that there will be political pressure that will bring these states along over time. The final question, will the ACA drive the cost of health care lower? Now, you hear the pundits argue this point, but I am absolutely convinced that it will, and I'll tell you why. Number one, will be, and as we all know, and to the chagrin of many of my colleagues, there will be lower Medicare payments to hospitals. More importantly, there will be an emphasis on value, not the volume of the medical care. And my personal favorite is the third one, the Obamacare startup boom. You see, over this country, entrepreneurship is very much in fashion. There are thousands of young entrepreneurs who are taking advantage of some of the nuances in Obamacare, and most of these are predicated on the new transparency. The new transparency. Is Chris Larson in the house? Chris, yeah, there's a young multimillionaire there, Chris Larson. Yes, yes, and the reason I wanted to point him out is because Chris is neither a physician or a hospital administrator, but he saw an opportunity. You see, right here in the San Francisco Bay Area, there is a wide range of differences in costs with just about any procedure. Look at that. Colonoscopy. Right here in the Bay Area, you can get a colonoscopy for $887 or $8,000. You can get a hernia repair for $3,500 or $16,000, and of course, everything in between. Gallbladder, $4,000, $21,000. So suppose that information were available to everyone, and suppose your deductible was such that you could make a decision to get the most inexpensive procedure. That's where the entrepreneurs will come in on that particular sector. But there are multiple avenues because of the transparency, the new transparency that the healthcare law has brought about. There are multiple avenues for opportunity the young entrepreneurs are taking advantage of. As a matter of fact, it is projected that there will be a $900 billion savings over the next 10 years. And we'll see. So, health care is a right. I want you to say it with me. Let's go. Health care is a right, not a privilege. Thank you.
You know, that is the most concise, plain-spoken analysis I've seen of healthcare in the United States. I don't know how many of you are healthcare educators, but I know that everything he said makes absolute sense to me. Yet, as somebody who's been involved in public policy at the state and federal level, you can't understand why members of the legislature and members of Congress don't get that. We're driving up the cost of health care without driving up the quality of health care. Something has to be done. And we as voters, we as people who are informed, need to get everyone involved in our community to understanding our health care, because a lot of us can't afford it, and unless we do something about it, that number is going to continue to increase, even with affordable health care. Next speaker is someone I had the pleasure of hearing at the California-Hawaii Conference of the State NAACP. And I was really, really impressed with his knowledge, not only of the subject matter, but his commitment and passion for the affordability and the access for health care. Throughout his adult life, he's been involved in providing health reform, health access, and affordability and efficiency to all those who are part of the healthcare system. While he has been involved in various state and local areas of healthcare, in his job prior to his current position, he served in the Obama administration as the director of Medicaid and medical efficiency and improvement. It is indeed, innovation, I'm sorry, is the correct title. It is indeed a pleasure to introduce to you the Executive Director of Covered California, Mr. Peter Lee.
Good evening. It is great to be here. I will say, on a number of fronts, I am very humbled to be here. First, given the past speakers that have spoken before you, some of my true heroes, people like Congressman Lewis, people like Congressman Young, but also following the future leaders that spoke earlier. Boy, do I wish I were that articulate now, let alone when I was in 7th grade. So I really am humbled to be here. I also want to appreciate that great introduction. You're absolutely right. That was one of the best introductions of sort of the broad context of the Affordable Care Act I've heard. And I would note that it's rare you see a cardiac thoracic surgeon be so, now I'm getting myself in trouble now, excuse me, but you know, the issues, he speaks like a primary care doctor. You know, he talks like, you know, he gets it in terms of what it means to change healthcare. So it was a great introduction. So as you know, this lecture series is anchored in building on the work and lessons of Martin Luther King. This is the first lecture that's really looking from someone that didn't, you know, I grew up during the Civil Rights Movement. I was involved in Pasadena and some of the issues around integration, but, you know, I am no icon, I'll tell you. But what we are doing here today, talking about the Affordable Care Act, goes right to the heart of one of the things Dr. King said, which is of all the forms of inequality, injustice in healthcare is the most inhumane. Okay. Now, he said that 50 years ago, and we can stand here today knowing that the work is not done. Dr. Ennis is right. We still have a lot of people uninsured, but we have now, as a nation, said health care is a right, not a privilege. Okay. And this really is taking a huge step to that path of having a more just America. I'd like to spend some time talking about how that's coming and what we've done here in California. Given this introduction, I'm going to talk mostly about the coverage side of things, but put it in context. But when I think about the pride that we should have as Californians, I'd want to start with the note that we've done some pretty good work here in California and in the nation. But the work we've done in California isn't about us folks in Sacramento. It's folks across the state in every single community. I've been traveling the state. I've been in the Central Valley. I've been in San Diego. And I've been a number of times here in Oakland, here in Alameda County. And a number of the folks are here tonight, folks that have helped make history. It's folks like the County Healthcare Services Agency here in Alameda County, folks like NAACP, folks like Lifelong Medical Care, folks like the Clinica de la Raza, folks like the California Black Health Network, folks like the Asian Health Services. These are groups that have been out there for a year saying, we're going to go from the dream to bringing that dream to Californians and expanding coverage. So we are starting to deliver on that dream, and it's been a beginning. But to be at a place where now you can no longer be turned away by an insurance company that says, sorry, got asthma, don't want you. Sorry, diabetes, we don't want you. You can no longer be turned away because you don't have enough money in your pocket. We in California, and this is a really important note, it was a great introduction, because of the leadership of our legislature and our governor, we said we're going to expand Medicaid, okay, which means about 1.8 million more Californians are eligible for Medicaid, and it means basically in California, and we've still got work to do because we are not covering the undocumented, but for all citizens, finances should not stand in the way of any Californian from getting health care. Financial help to get a leg up to buy a health plan they picked through Covered California, or to be newly eligible for Medi-Cal. That is historic. That is life-changing, and it's happening because of the work of people across the state. So let me give you some of the context of where we are, and then talk about what it's take to get here and some of where we're going. So we just ended this thing called an open enrollment period. Now, in this period, which ended on March 31st, 3.3 million Californians got health insurance coverage. Okay, And it really is, and it's to the credit of people around this room. So 1.4 million signed up through Covered California. Most of them got a leg up, helped buying the private plan they chose with a federal subsidy. Another 1.9 million signed up for Medi-Cal. Now, behind every one of those numbers is a person. I'm actually going to not ask you to shake your keys, but I'd ask you to, if you know a friend, a neighbor, a family member who in the last 6 months has signed up and gotten health care, please raise your hand. Now you look around. Just look around. Keep your hands up. Keep your hands up if you could for a second. You know, 6 months ago, when thank you can put them down, I was spending time in churches, and I said, if you know someone who does not have insurance, raise your hand. The same number of people raise their hands. And what we're seeing is, you know, and my sister's in the crowd with me. I'll note that our nephew did not have insurance 6 months ago. He does. You know, I've been in churches, I've been in schools, I've been across this state. It's touching people's lives. And I've heard the stories, and I've had people on our service center, they're answering the phone saying, I've had people break down in tears, saying, I never thought health care would be something I could afford. I never thought I'd get through the door of that insurance company, and it's changing people's lives. You know, I heard from Hugo in Oakland here. He talked about skipping his heart medication doses. He cut the pills in half until he got covered. People like Camila in Elk Grove, she only went to the emergency room. That was it. Now she's saying, first time, I'm going to get preventive care. Julia in LA says she actually is going to think about her career choices not based on where she can get health care. Because she can get health care, but she can follow her dreams and create a new business. These are what it means to be providing health care coverage to all Californians, to all Americans. Now, this is a very big deal. And I'd note that having insurance does matter. Now, there was a survey done last year about Californians. And last year, 1 million Californians spent their entire life savings because they were not insured. They had to spend that because of health care they got without insurance. Last year, 100,000 Californians declared bankruptcy because of not having health care coverage. Many Californians who had health insurance were surprised when it didn't cover what they thought it was going to cover. They went bankrupt. You know, I look forward to the day, and we should be there, when medical bankruptcies are a thing of the past. People are not avoiding getting preventive care. They're getting an ongoing relationship with their doctor. So, now, let me talk to you about what the Affordable Care Act means, because the Affordable Care Act changes the health insurance industry in many very, very fundamental ways. So, first, up till now, and I say this with huge respect for Kaiser Permanente and other insurance companies, but in many ways, the business of insurance was to avoid sick people. That's how insurance companies would make money. If they did a better job excluding people that were sick, they'd make more money. Okay? The Affordable Care Act totally changes the rules of health insurance in America. Okay? It says, first, you've got to take everybody. You cannot screen them for health conditions, and you've got to take everyone, and you can't charge them differently. So that's what's called guaranteed issue. That's a big deal. But it also says, if you're an insurance company that thinks you're going to play by the old rules, and you're going to say, I'm going to avoid those diabetics, and I'm going to play games with underwriting, well, you can't underwrite, but if you do, we're going to take money from you as a health plan and give it to that health plan that has more diabetics. It's called risk adjustment. It's changing the rules. Okay? It's also changing the rules by saying, health insurance company, you've got to spend the vast majority of the money you collect in premium on health care. Okay? Not executive salaries, not marketing, not administration. You've got to spend 80% or more of every dollar you bring in for premium on health care. If you don't, you've got to write a refund check to the people that paid their premium. That's changing the game. And it is, as Dr. Enoch noted, it's about moving the healthcare system to be about quality and value, not about avoiding sick people. Okay? That's a new game. The Affordable Care Act is delivering that new game. So, other things the Affordable Care Act did, and I really appreciated the 6 major elements, but there's other elements that are in place too. The Affordable Care Act, for seniors, for the first time covers preventive care. Believe it or not, Medicare did not cover preventive care up until the Affordable Care Act. The Affordable Care Act expands coverage for prescription drugs for seniors. And the reason I want to note that is 50 years ago, we passed Medicare. Now, I wasn't around then, but my dad was and very involved, and you may be shocked to remember that it was actually controversial. When it was passed, the AMA said this was going to be the fall of the Western civilization. It was going to be communism coming in. It was going to be terrible. It was going to be awful. When it was passed, it was not perfect. It was bumpy. Took a while to get right. It didn't cover drugs. It didn't cover preventive care. It does now. The Affordable Care Act is now, in many ways, to my mind, 3 months in. So we actually opened our doors for insurance as of January 1, 2014. It's been bumpy. It will be bumpy. But what we're going to do is the same thing we did with Medicare. When we look back 10 years from now, we're going to say, can you imagine there was a day in America when we didn't make sure that every American had health care? What's that about? And I look forward to that day. We are still, in many states in this country, you saw that southern band of states that didn't expand Medicaid. Well, they have lessons to learn from California, and that's what I'm going to talk to you about, the lessons they can learn from us. So let me give you a picture of what happened in our first open enrollment period. So first, define the terms. What's open enrollment? Open enrollment was this period we had from October 1 to March 31st. During that period, a health plan could not turn you away in the individual market. That's for individuals, okay? During that time, you can get financial help to get coverage, okay? Now, open enrollment closed on March 31st. Okay? That doesn't mean your ability to get health coverage closed, because health plans can't turn you away if you've lost a job and lost insurance. They can't turn you away if you've moved to the state on an ongoing basis. And they can never turn you away from Medi-Cal. But they will turn you away, either at Covered California, or if you knock on their door, if in June you heard everything about this coverage thing and you said, I'm not going to buy that insurance. I'm going to come back when I need it. Then the plan, or Covered California, said, sorry, you got to wait till next year's open enrollment period. That's going to be next November. So this open enrollment period is actually a significant and meaningful thing. For those that did not hear, so that somehow were under a rock and didn't hear about the Affordable Care Act, didn't hear about Covered California, and did not get coverage, and said, I'm going to take a risk, they can come back next open enrollment. We're going to be out here again. They will pay a penalty, okay, when they file their taxes for 2014. But I'll tell you, when I was out there talking to people, the penalty that I care about isn't the 1% of your income, that's what the penalty is. The penalty is showing up in an emergency room and having one of those $40,000 procedures that you're on the sick for. That's the penalty we want to make sure people avoid. So, where are we with this? Well, as I noted earlier, 3.3 million Californians now have coverage that didn't when we started this venture a little over 6 months ago. 1.4 million enrolled in Covered California through the private plans that we selected. Now, there were estimates by independent folks on how many people we might enroll at Covered California. And the highest estimate that was out there was a little less than 900,000 people. So we enrolled almost 50% over the highest estimates. Compared to some of the base projections, we exceeded projections across every region of the state, across every demographic group, for Latinos, for African Americans, for Asians, and we still have a lot of work to do. In some parts of the state and in some communities, we did better. But in every part of the state, we exceeded what were any of the independent expectations, but that's not enough, because we still have millions of Californians that don't have health insurance. We have lessons to learn that I'm going to talk about. So how did we, relatively speaking, succeed? And I say relatively because, again, we are still a state that did better than virtually any other state, but still has 3 million uninsured. Well, we did that because our success hinges on 3 key things. First, having affordable health plans that we're offering. Second, doing effective marketing so people know about it. And third, getting people enrolled. Okay, I'm going to go through these 3 pretty briefly because I want to make sure we get time for some dialogue and questions. But I think it's important to give you the context of how did we make this thing work relatively well. So first, affordable health care. And again, it's so great following Dr. Enix because Covered California did not make health care inexpensive in America. I mean, that's really important. The charts you saw, we are the most expensive country for health care in the world by a factor of 2. Okay? With that, we went out at Covered California and said, we aren't going to take any health plan. We're going to be a very active, picky purchaser on behalf of consumers. 33 health plans said they might be interested. We ended up selecting 11 health plans. Okay, now, in some communities, there's as many as 6 health plans competing, like in LA. In other areas, as few as 2 in rural areas. Alameda County has 3 health plans, but there's actually some zip codes within Alameda County that only have 2 plans being offered. Okay? And we couldn't tell the health plans what to offer. We said, come on in, develop networks that are going to be good networks that make sure people can get care. Bring your best price because affordability matters. Okay? The other thing we did as an active purchaser is we said no more of this shell game of benefit designs. Okay? Up until now, people said different plans would have a different co-insurance rule, a different deductible, a different copay. We said standard benefit designs. So when you go to coveredca.com, and the doctor showed healthcare.gov, that's in California, it's coveredca.com is where you'd land, and you're comparing the health plans that you might choose from, you didn't need to worry to say, oh, is the deductible different? Same deductible. You can say, oh, it's because I believe in the delivery system Kaiser has, or I've got this doctor over here, I want this network. So by having standard benefit designs, we're actually having consumers back. We're giving consumers a way to make standard choices. The other thing we did by having standard benefit designs, and this is we're one of the very few states in the nation that did this, is we designed the benefits to encourage people to get care when they needed it. Okay? Far too often, if people are relatively low income, they're going to say, $45 for an office visit. I think I'll skip that visit. Okay? The subsidies through the Affordable Care Act take their form in 2 ways. First, sliding scale reduction of your premium. So you make less money, you get more financial support to pick the plan, and then you pay some balance. And what you might pay could be as low as $1 a month, could be $40 a month, could be more if you make more money. The other subsidy, though, is in the form of reducing what you spend out of pocket. So lower income Californians that make too much to get into Medi-Cal, but make, $20,000 a year, for them, we developed designs that says, office visit for you, $3, not $45, $3. All the plans have to offer the same benefit designs. And we've made designs that would encourage care to be available and accessible instead of having co-payments being a barrier to care. So that was our start. Affordable plans being offered at affordable prices, but not cheap, because healthcare is still expensive in America. Second, effective marketing and outreach. Well, a year ago, no one had heard of Covered California. Today, 90% of Californians know this thing called Covered California. They've got a basic idea of what it is. Why? We started at the grassroots. We started working with community organizations across the state, groups like the NAACP, groups like the California Black Health Network, groups like Visión y Compromiso, groups that were out in communities doing education about what is this healthcare reform thing. We started with 250 groups in every community in the state because we recognize that this is complex stuff, and the place to start is with trusted voices in communities. Okay? We layered on top of that marketing. Now, we did targeted marketing in African American papers, on telenovelas, on Univision and Telemundo. We did advertising that was targeted at where people that are lower income, eligible for subsidies, are going to watch, are going to listen to, are going to be on the web. Now, I did note that some of you have given up Facebook. So we're out there on the web quite a bit, and social media is an important avenue. And so we're out there across the board, but we're pairing that in-person contact with community-based touches with broad-scale marketing. And what do we find? We found a lot of engagement, but we also found that we needed to be agile. 3 months in January, we were looking at our data, we're saying we are not doing as well as we should be in some parts of the state. We are not getting as many people enrolled who are Latino and African American as we were in other parts, in other demographic areas. So we shifted our strategy and put more resources in community organizing in 7 parts of the state, more local advertising in ethnic media, and that showed results in the final 3 months that we had going into March 31st. But we still have work to do. Next, affordable products, and people know about it, then you got to enroll them. Okay, now, healthcare is complex. I was talking to a reporter today that says, Peter, a year ago, you were quoted as saying you were going to make buying health insurance as easy as buying a book on Amazon. I said, okay, it's not that easy. But we're trying to make it as easy as, how about doing taxes on TurboTax? So health insurance is pretty complicated. But we built a enrollment system, coveredca.com. We did it in 18 months. We had 12 million unique visitors on that site. That site was up and running more than 90% of the time. 90% of the consumers got instantaneous access when they were on that site. Didn't work perfect, but it worked pretty darn well. And compared to the federal site, unfortunately, which had a lot of struggles, a lot better than that site. What did that mean? Well, it meant that of our 1.4 million people that enrolled, 40% did it online. They did it online. They were able to go end to end, pick their health plan, get the subsidy, choose a plan. But very importantly, enrollment often requires a human touch. Okay? 60% of the people that enrolled had a human touch. Now, most of them were helped by certified licensed insurance agents across the state. People that have been helping people understand insurance for many years and now help people get across the line and get subsidies and make the Affordable Care Act work. Also people in county offices, also certified enrollment counselors. People need help. In many cases, insurance has not been made simple, but because of having literally 30,000 people across this state, people in county offices, insurance agents, certified educators, certified counselors, we made history. So we think we've had a pretty good start, but we're not done. Let me tell you a little about where we're going. And first, it's our board, and Covered California is an independent part of the state, and I work for a 5-member board, said from the get-go, we are not just about coverage. Coverage is a means to an end. We're about making sure people get the needed health care. The health care they get to stay well, to have preventive services, and to get care when they need it. So we are engaged right now in making sure people that enrolled in Covered California are getting the care they need when they need it. And we're looking right now at how to make sure that the contract provisions we have with our health plans that tie them to make sure they've got good enough networks that are available and accessible are actually delivering on that promise. We're making sure that provider directories are updated because they weren't right out of the gate. Some of the health plans were less than perfect, is an understatement, how some of their directories were out of the gate. So we've been working to make sure they get the directories right. We've been making sure that when people have problems at our service center and at the plans, we solve them. And this is because, again, it's not just about coverage, it's about making sure people get the care they need. It's about right care at the right time. It's also about our continued efforts for enrollment. So we have a right to feel proud about what we've done as Californians. But millions of Californians did not get across that line to get coverage. Today, open enrollment's closed, but we're in what's called a special enrollment period. That means if you lost your job and don't have health insurance, come on down. You can get guaranteed issue coverage, you can get a subsidy. You moved, come on down. You make less than 138% of poverty, which is about $16,000 a year, you're eligible for Medi-Cal year-round. That's a core message that we have out there that we're going to be out there all the way to our next open enrollment period, which will be this coming November. That next period, we're right now reviewing all the lessons we've learned from this first 6 months, historic 6 months, of saying what worked, what didn't, and we're in the process of reviewing that to make sure next open enrollment we do an even better job. Now, it's going to be harder. Because in many ways, we reached pretty high up into that tree. The low-hanging fruit we already got. We got people now that are saying, I really don't think that insurance thing is for me. We're going to need to do more education, more outreach and engagement, and we're going to build on our lessons. So why did we do a relatively good job? And I keep on saying relatively good. Now, California represents about 1 out of 5 American that has gotten coverage through the Affordable Care Act. That is huge. That's double our portion of the population. Well, I got a number of reasons why I think it's happened. Is first, our leadership, and by leadership I mean our elected leadership, across the state has focused on consumers. We've said we are not going to have California consumers be pawns of playing politics. And it really, I've been in Alameda County, but I've been in Orange County. And folks have said, we are not going to play political football with Californians. And we've had the entire state say, let's make this thing work. Second, we've worked effectively across the state. So I partnered with the Department of Healthcare Services, which runs Medi-Cal, the regulators. we've been flexible as an organization. We said, if we don't have it right, we're going to learn, we're going to look at data, we're going to shift strategies. But the biggest thing that's made a difference is this has been an initiative of all Californians. It's been about insurance agents, chambers of commerce, community clinics, unions, labor organizations, philanthropic groups, doctors, nurses. This has been a labor of love for Californians saying, we've waited 50 years for this, we're going to make it happen. So we're not done. In many ways, we're just beginning. But it is a time that I am very, very proud to be a Californian. And when we think about this, I'm grateful for all of you that have helped make this possible. Because, I would bet many of you talk to your friends, your neighbors, your families. That's what it takes to make history. You do it one person at a time. The Affordable Care Act has, for our future, changed healthcare in America. It's going to keep on changing, but what we've done in California is demonstrated to the rest of the nation how to do it and how to do it in a way that puts consumers first. And I agree with Dr. Enix. You look at Florida, you look at Texas. Texas has 24% of its citizens without health insurance today. They will be looking at California and saying, we need to have what California has. And it's because of the leadership we see of people across this room and across this state that I think we're serving as an example, and we've got a great beginning, and it's so great to be with you, to join us as Californians in leading the way. Thank you all very much.
At some point, we need to have a national conversation about health care, access, and costs. This has just been a beginning of that conversation. I hope that everyone who's been here today has been a little bit better informed, certainly has been able to form their own ideas, questions, and answers as it relates to health care. And I want to thank Peter Lee of Covered California, Dr. Enix for sharing his perspective and information and education, and thank all of you for taking the time to hear this lecture and to be able to, again, be better informed as citizens of this community in the state of California. So thank you very much for coming.